It's really a great pleasure to welcome you all this afternoon to the Captains of Industry Talk and to introduce our sparkling speaker for the afternoon, Anne Gow. Now, Anne is a qualified nurse, midwife and health visitor. She's currently Director of Nursing, Midwifery and Allied Health Professions and Deputy Chief Executive at Healthcare Improvement Scotland. And we are also very proud to say that she's a graduate of Glasgow Caledonian University, and she's just told me she's a double graduate of GCU, so very special. Now this afternoon, Anne's going to share her career journey with us, sharing lessons learned along the way, but with a particular focus on her leadership of the creation of a new hospital, the NHS Louisa Jordan Hospital, during the darkest days of the COVID pandemic. Anne will also share her perspectives on the impact of COVID on quality and improvement of the health and care system. But first, a wee bit more about Anne. Prior to joining Healthcare Improvement Scotland, Anne held various senior nurse leadership posts in NHS Ayrshire and Arran before moving to Greater Glasgow and Clyde as Chief Nurse for Regional Services. She's worked in the Scottish Government, contributing to the development of policy, and she secured the post as Scotland's first nurse consultant in public health, that's my discipline, in NHS Greater Glasgow and Clyde in 2000. Within Healthcare Improvement Scotland, Anne provides leadership for, as we say, nursing, midwifery and the allied health professions and their teams to continuously improve care. She's responsible for supporting the implementation of newly introduced safe staffing legislation across Scotland. We are so grateful for everything you do for our health service and for your university, Anne, and we're really thrilled to have you back with us this afternoon. So without further ado, I'm delighted to introduce Anne Gow to deliver this afternoon's talk.
Thank you. I don't know if I can live up to that introduction. Pamela very kindly, I'll start off a wee bit about my early career journey and then what had taken me to where I am now. And then, as Pamela said, focus a bit on what we've been doing, what I've been doing personally over the last 2 years during COVID, with a focus on the Louisa Jordan, but also talk a wee bit about some of the work we've done in care homes, some of the work we're doing across the NHS. And of course, much as we would love it to be, it's just not, COVID's not over. So I think we'll have the COVID legacy for years to come. And having looked at the invite and acceptance list, I'm really delighted that so many of you are undergraduate students, because you're the people who be taking the NHS and social care, I think, through its next stages and its next steps. And some of the learning from COVID that you've had, even working as students or very early graduates, I think will be absolutely invaluable. And we really need that new fresh thinking through the whole system. So Pamela very kindly said that she wouldn't mention the years in my graduation, but I'm just going to let the cat out of the bag because I am. So I grew up west of Scotland, typical working class west of Scotland upbringing in the 70s in Paisley, middle of 5 children, big Irish Catholic family, part of a big Irish Catholic family network. No one had ever been a nurse, a doctor, or actually indeed been to university or done higher education in the family or extended family, as was kind of normal then. So for those of you who are maybe a bit my age, and there'll not be many of you, I had in my very early teens, I think, wanted to join the police because I'd watched Charlie's Angels, and I thought it'd be quite glamorous. One of my mum's friends was a police officer and managed to talk me out of that one. And then I went and got my tonsils out in the old REI in Paisley when I was 16. And was in an adult ward as a 16-year-old, absolutely terrified. They didn't allow parents in to visit and things apart from an hour a day. I mean, it was looking back, it was pretty awful, and so glad things like that have changed. But there was a student nurse, I think she was at the time, who was exceptionally kind and spent a lot of time with me, made sure I wasn't in pain, made sure I wasn't too frightened. And I looked at her and thought, I'd quite like to do that. I wonder how I do that. At the same time, I was on track at school for getting 5 hires, kind of mix of sciences and arts and things. I thought I'd quite like to go to university as well, so I wasn't quite sure what to do. And at one point I thought, what I'd quite like to do is English and history at university and then go into nursing. went along to speak to someone at the RAI who said, do you know they do undergraduate courses in nursing now? And I hadn't been aware, and you should maybe think about that. So I spoke to Glasgow University, who asked what university my brothers had been at, and that just made me laugh. And then I came to, I don't think you go to university to be a plasterer and a bus driver, but and they were very clear that, you know, that your parents would have to be able to support you, and you did the undergrad course there, came to the Cali, the Tech as it was at the time, and just felt at home, came for the interview, was offered a place in the course, and that was me started on a career that I've had and has you know, kept me going and really served me through my whole life. At that time, kind of society-wise, there was a whole lot of deindustrialisation. In Paisley, where I grew up, the mills had closed, my dad's work had closed, there was no engineering works anymore. Politically, we had the Tory government, and you know, Thatcher government was kind of just coming into its own, and the Tech as it was a hotbed of left-wing socialism, I think. And of course, but you know, in part, our degree, although it was a mix of science and arts, in part was social sciences. So inevitably, a core of, we had a reunion a couple of years ago, we were talking about this, a core of our undergraduate training really was learning how to be politically active. And the Black Report, having just come out about health inequalities, absolutely shaped, I think it shaped all of our careers from then on in. So as undergraduates, we took part in numerous sit-ins and protests around, you know, at that time, student grants were going, the minimum grant was going. I'm sure you would love to have a minimum grant now, but certainly that started off my interest in inequalities, and which has been a lifelong thing. So I think my first job at the Western Infirmary in medical receiving, I noticed when I was there that a lot of people who were coming in with MIs, heart attacks, with other diseases, disorders, a lot of what's called mesothelioma, which is related to asbestos exposure, were coming from Clydebank, Drumchapel, and areas of where there were high ethnic minority populations at that time, like Woodside and Maryhill. And that sparked my interest again in the whole area of health inequalities. So I looked around the various branches of the nursing profession and thought, what can I do that would allow me to pursue this passion? And saw health visiting, which was in the public health part of the register. I'd love to do that, but to be a health visitor at that time, you had to be a midwife. So trained as a midwife in Paisley, and then got the opportunity to come back again to the Cali. I felt like coming back home and doing my postgraduate health visiting. I think it was a postgraduate diploma or certificate at the time. So from there, I went into health visiting, which I absolutely loved. Felt most at home, I have to say, working with deprived communities. So worked in Hamilton, worked in Paisley, worked in Johnston, but was getting increasingly frustrated that some of the problems that I was seeing, I worked with some really, really strong young women and men who were parents living in really, really deprived circumstances, but was getting really frustrated that I wasn't able to influence. None of us seemed to be able to influence their life circumstances, which were underlying some of their parent issues. Found a bunch of like-minded health visitors, and we formed ourselves into a group called Promoting Public Health and Nursing. And Julie, and I don't know where we got the courage, but anyway, Julie knocked on the door of the Scottish Government, which was new at the time, because we've just had devolution about that time, and said, we need to do more. We feel as nurses we need to do more. We're not doing enough in nursing to promote public health. At that time, I had moved into a community development job, so working in Johnston and 2 areas of deprivation, working with local communities around assets-based community development. So some of you might have done a bit of community development in your undergrad programmes. Absolutely loved it. That had a great time, really loved the people that I worked with, the community reps and everyone else that I worked with, and felt that this was the way forward for health improvement. So rather than spending our time screening and looking for problems that people were having with themselves, their parent and their children, actually looking at the assets in a community and how you can build community assets and how you can change people's outcomes. so one thing led to another, and a job came up at Scottish Government at that time. Kind of that was sort of 99, 2000, around about the time, as I say, of devolution. I hadn't realised how exciting it was to be working in the government just at devolution, a brand new government at the time. It was a Labour government at the time. Susan Deakin was the health minister, with a real interest in health inequalities and a real interest in a lot of the things that myself and a lot of my colleagues we want to do. So I spent 2.5 years there working on developing promoting public health and nursing policy. So we called it Nursing for Health eventually when it was launched. I probably would do it differently now. I think we had 70 odd recommendations. We had absolutely no hope of implementing all of them. But I was young and inexperienced in a young and inexperienced government at the time. So, but it did make a bit of an impact, and I think changed and shaped the future of health visiting. For myself, it gave me another opportunity, which was to move over to Glasgow again and work in Greater Glasgow. It wasn't Anne Clyde at that point, it was Greater Glasgow Health Board at that point, the Clyde bit added later, as the first nurse consultant in Scotland. So nurse consultants were announced, I think, as part of an English DOH announcement, and it was decided in Scotland it would be a good thing to get some nurses in, to promote some nurse consultants. So I was the first. My colleague Anne Holmes, who was the chief midwife until recently, was a midwife consultant, and the two of us worked together on a lot of early years work with young children, and also in embedding public health and health promotion approaches across all the other branches and disciplines of nursing across Glasgow. And also got the opportunity to present at conferences. I was on the kind of NMC as it's in its inception, on their council, promoting public health and nursing at that point, and just loved it. Made masses of changes that are still kind of ongoing in Glasgow. Redesigned the health visiting service. Had them much more, evidence at the time was pointing much more towards kind of early years being where a lot of the problems start. So we refocused health visiting on early years. And we had probably the beginnings of, we had a number of programmes like Starting Well, which were the beginnings of some of the early years work that's much more targeted early years work that's around at the moment. And we did things like trained community mothers, got them some SVQs, young women who'd had to leave education very early, and tried to get them into entry into further education and so on. So it worked really well. And as I say, thoroughly enjoyed it. So I did that for 9 years. In the middle of that, had my daughter, and was kind of towards the end of the 9 years, public health was changing again. We had a new government. I think SNP were in by that point. Things were less about community, a wee bit more about individuals. And I had a mentor at the time who was a public health medic, who had said, we're now starting to train people in public health as non-medics. I think you need to decide whether that's what you want to do or whether you want to stay in nursing and use your leadership there. And I hadn't really thought about it. I thought, I want to do it. But actually him saying that highlighted to me that I think to my core I was a nurse, and much as I enjoy public health, it was the influence that nurses could have on improving health rather than public health as a science in itself. So I probably completely disappointed Pamela, whose whole career's been in public health. But that focus on inequalities, on health improvement, on early intervention is there, knitted into my DNA, and is still there, and has been in the jobs that I've done subsequently. So that left me with a bit of decision to stay in Glasgow and continue with my public health career, but focus on, at that point I was leading on obesity. I think we were planning, I seem to remember, we were planning the Queen Elizabeth at the time, and we were planning the Commonwealth Games and the response to the Commonwealth Games and with the local authority, and doing loads of interesting stuff around, obesogenic environments and making sure that people were able to walk to places, and the cycle scheme and a lot of other things again that have come to fruition now that we managed to be involved in. But that mentoring opportunity really got me thinking, and it got me into a fork in my career. So I think by that point was also very expert and very specialist. But a bit of a lone wolf, so worked across a number of different teams, but was used to being an expert single person, did a lot of lecturing actually again back at Glasgow Caledonian and at Glasgow University, asked to speak at conferences, all sorts of kind of national, international, UK-wide working groups. But if I was to continue, I think I would have had to stay, go on to the public health register, probably become more interested in disease and disease outbreaks. And actually that wasn't where my heart was. So the opportunity to come up again for a bit of a sideways move to work in government again on the early years framework, which I did. And while I was there, I was only there about a year when an associate nurse director job came up in Ayrshire and Arran. And focusing on primary care with an aim to redesign their primary care nursing services, which was absolutely ideal for me. So I managed to secure the job, which actually was quite difficult because I was going from quite a specialist area to something that was a generalist nursing leadership job, and was a bit of a leap for me. So I had gone from being a single recognised expert to jumping sideways and being one of many associate nurse directors. And I think for me that was a kind of really pivotal part of my career. However, what I relearned was, and what stayed with me since then, is the importance of team. So working in a team, Ayrshire and Arran at that point, and still do, arrange their leadership teams and triumvirates. So nurse, doctor, managers. So there's myself, associate medical director and head of primary care. At that time, kind of in terms of wider context, there was the Vale of Leven review, if you remember the disease outbreak at the Vale of Leven. There had been kind of around that time, there was a mid-staffs review and a real focus then on safety and improvement in the Scottish safety programme. So I managed to kind of do two things at the same time: restructure in Ayrshire and Arran their community nursing programmes, their community nursing structures, their focus, to get them much more focused on early intervention, some of the things that I've been working on and interested in. And at the same time, I learned absolutely loads. And one of the things that I became involved in was the patient safety movement. I was fortunate enough to do some patient safety training at exec level and become more involved with the International Institute for Healthcare Improvement, which is America-based but works across the world. So that was, again, a kind of really pivotal moment for me. The other thing that I did at that point, and again was really, really fortunate to do, was do the Delivering the Future leadership programme. And what that taught me, one was the value of teams. We did a whole load of action learning that actually most of the issues that we're going to have at work, and I think most of the issues that we do have at work, because most of us work with other people, are relational issues. And if you can work with people, you can work with teams, you can inspire other people, then that's how you're going to get outcomes. It's not just about being what I had been before, which was a single expert. And part of the SPSP thing, and again, this is going back to kind of pre-me, although it does feel like maybe when I was very young, but Florence Nightingale days, when Florence Nightingale primarily wasn't a nurse, was actually a statistician. So part of the whole patient safety movement is using statistics to measure outcome, and doing that in very rapid cycle change movements so that you can see whether or not what you're doing is making a difference. And that's what I feel had been missing, I think from previously in my career, because public health is very much about long-term outcomes. So there was a bit of being able to combine the two disciplines and work on improving health visiting services, improving our prison healthcare services, which I had the opportunity to transfer over, which was a massive learning opportunity for me because I've never worked with prisons and prison healthcare before. Massive learning opportunity, and also to learn a bit more about myself through coaching that I'd had through Delivering the Future. So I think from there, I learned some of the fundamental leadership principles that I wish I'd learned before. So as I say, team, the knowing myself and know what my preferences are and being absolutely comfortable with myself. So I know I'm quite introverted. I know I'm not, I was just saying to Gillian before we started, on the Myers-Briggs scale, I'm quite a high T. I'm not for a nurse, I'm not particularly touchy-feely and not great with hugs and things. And also I like process as well as outcomes. And that actually that's okay, and that leaders can be many different things, many different personality types. And in knowing yourself, you also know who you need in your team, because you need people who are different from you and have got complementary skills. So those were kind of fairly fundamental. Should probably have known them earlier, but big things for me. I then became, in Ayrshire, the interim nurse director. Our previous nurse director, who was incidentally also a graduate of the Tech, had gone on to be the chief nursing officer of Fiona, and I filled her post for a year. And one of the things that happened at the end of that year was that I didn't get the job because somebody else got it who had much more experience than I did. And again, was pretty, one of the pre-submitted questions was, what if I don't get the job that I want? It's fine if you don't get the job that you want. It doesn't feel fine at the time, but it's absolutely fine, because I wouldn't be in the job that I'm in now, and I wouldn't be talking to you if I hadn't got, if I had got that one. So again, that was a kind of a bit of a learning experience for me, and a bit of a stop and, who am I? Would I like? What are my motivations? What is it that I enjoy? What I feel passionate about? And the job came up at Healthcare Improvement Scotland, which was combining all of that, and was absolutely ideal for me. So I moved to Healthcare Improvement Scotland 5 years ago now. There was no nursing team. They had never had a nurse director. It was formed in 2012. It had a clinical director who was a medic, and had really poor relationships, I think, as a result, with nurse leadership across the country, but needed nurses, midwives and AHPs, but nurses in particular are the biggest workforce in the NHS, 65,000 registered nurses in Scotland. So if you can influence nursing or midwifery and AHPs, then you really are not going to influence healthcare improvement across the piece. And given that nurses also work in social care, they work in the independent sector, they felt it was really important. So over the kind of next 3 years then, we built the nursing team within his. We've now got, I think, there's about 50 of us, from starting with 2, and we focused on particular areas. So one of them being the healthcare staffing legislation, which we have been about to implement, and because of our learning from mid-start, as I said earlier, and some of the learning around SPSP and the Vela leaving, and feedback we got from Vela leaving families, we built a quality assurance system that oversaw standards, or will allow us to oversee standards at Frontline across all of Scotland, and at team level, and it'll allow local teams to own their own improvement, and the way that we had learned in Ayrshire and Arran. So that was all going swimmingly. I was also asked to be Deputy Chief Executive. I think a lot of the kind of operational experience that you gather as a healthcare professional working in territorial boards is really useful in terms of running an organisation. I had completely underestimated that. So as Deputy Chief Executive, I'm responsible for internal improvement, for instance. I'm also got responsibility for maintaining our relationships with Scottish Government and making sure our strategy aligns with policy and so on. So had both of those things in line. We were just about to implement the healthcare staffing legislation, just about to launch our new care assurance programme, just about to spread our training and quality improvement in March 2020, which will ring a bell to everybody, when COVID hit. So my COVID experience, very, very early on. So our organisation is not Frontline. We have some clinical staff, and we've got a whole load of people like healthcare economists, healthcare scientists, we've got pharmacists, we've got, and we've also got people who specialise in community engagement, but we're not Frontline. So the first thing that we did was actually stand back and stand down to allow territorial boards to be able to deliver what they needed to deliver. And we did that for about a week. I worked at home, I think, for about the first week. I remember emptying the offices on the first day, saying we might not be back here for 3 or 4 weeks, so please take any sandwiches and fruit from your desks. Little did I know, 2 years later. And about a week into my working from home experience, which was frustrating me to death, I have to say, I got a phone call to say, do you think you could go along to the SAC? The Army are there, and we're thinking about setting up one of these field hospitals. I had seen on the news, probably the beginning of 2020, that China had set these up in 3 weeks and thought, no way, they haven't done that. You know, there's just no way, you couldn't possibly. And here was I, first day being asked to do that. So I got to the SEC on a Sunday morning. I think it was the 30th of March 2 years ago, and met with the person who'd been appointed, Jill, who'd been appointed as the chief exec, and the person who was appointed as the medical director, and the three of us were asked to go on with it, and could we build a hospital in 3 weeks. It's a bit of mentoring for that first day from the army, but it was the engineers from the army at the start who were telling us how to make quick decisions, got us into a gold command structure, and loads of help from the construction industry, who had been asked to work from home and stood down from, there was a whole team of them had been working on Queen Street station, and had been asked, so they had all stood down and were working together rather than competing with each other, which was really interesting, and they loved it because a lot of the workers all worked for different companies anyway. A load of help from them in terms of actually doing the build. So using all of the experience that I had, and a network of individuals that we'd built over over my career, I managed to get together a team of most of them newly retired individuals, because people who were still active in the health service were of course still busy doing other things. And we built, in the space of that 2 weeks, we built a governance structure in the first 2 days, which normally would take you a couple of years. We managed to work with the procurement teams and the builders to design a hospital that wasn't going to harm anyone any further than they already were, because that was one of our basic principles. We worked across all of Scotland in the clinical teams, because the idea was that the patients would come from any health board, to look at how we would define our clinical model, which would then define the build and would define what we were going to buy, procure in terms of equipment. And what we decided on was that we could really only look after people who had COVID. At first it was to be a 1,000-bed intensive care unit, but we realised very early on that we probably wouldn't need that. So we had I think about a 300-bed intensive care unit, and the other 700 were for people who were step up or step down. And we built a whole infection control system around that. Some of the biggest challenges I think we had in that first couple of weeks were in procuring equipment. So it wasn't just us, and that's what struck me in the first couple of days, was it wasn't just us who were doing this. Every country in the world were trying to get hold of hospital beds, we're trying to get hold of ventilators, we're trying to get hold of, at one point we had no commodes, and there aren't toilets in the SEC. There are a few scattered about for people going to concerts. There's not toilets for patients. We had to work, I was about 12, 14 hour days working with the architects. At one point, I remember lying on the floor to see if the lights would shine in the patient's eyes, and working, kind of meeting with the builders 2 or 3 times a day and saying things like, well, that looks great, but you can't put the buzzer there because nobody's going to hear it. It's so basic stuff like that. So that was kind of week 1. In Louisa Jordan, and we got the build. So by the end of kind of the first week that we'd been in, the builders did an absolutely fantastic job and had the whole thing, at least one of the rooms, up and running. And then we get into how do we do the clinical model. So I was aware that one of my nurse consultant colleague, one of my nurse director colleagues in Orkney had an army background. So having learned from the army about how we make decisions quickly, David came down and helped us out with how do you set up a field hospital. And we learned loads from him that we're writing up at the moment, and we'll get out into the rest of the system about things called rock drills, which I thought were a bit, well, I'd assumed because it was the army it was something to do with being outside and rocks, but no, it turned out it was rehearsal of concept drills, which we're using again now. So the rock drills allowed us to build a clinical model so that we're absolutely in a state of readiness for the whole load of brand new staff. We were absolutely in a state of readiness to take that first patient in that first day. Thankfully, after about 3 weeks, because we'd had the lockdown, it became evident that we wouldn't need it. We weren't going to have that tsunami of COVID patients, which was an absolute relief. But we did spend the next couple of weeks after that then saying, right, well, what do we do? Do we do what they've done in England and mothball what's a really good facility, or do we find an alternative use? So we did kind of the same thing again. We rebuilt a new team, and we had a lot of discussions about what can we do safely here, because space in the hospitals has been limited, because we needed more bed spacing, we needed to keep the 2 metre distancing, we knew waiting lists were getting longer, and we also knew we had a vaccination programme. Thankfully, by that point, we had a vaccination programme coming up. So again, having learned, thankfully, the importance of teams and the importance of getting different people in and around the table to make decisions and to work together, we decided at that point that although we weren't going to use it for COVID patients, actually, and we couldn't use it for things like some of the suggestions we'd had, I think, were things like, you know, could we not use it for surgery? We've got a big backlog. So no, because it's an exhibition centre with beds in it, so that's not on. But it was a good, it was a good environment for outpatient appointments, for instance, and for vaccination appointments where you needed more space, where you could have vast volumes of people coming through in a very short period of time. And that's what we did. And then at that point, I think that was maybe about the August 2020, about that point, I decided it was probably time for me to step back, because having spoken about my career, you'll be aware that my experience is in outpatients and a bit in vaccination, but certainly not in outpatients and in running waiting lists and things. So I stepped back, and the Golden Jubilee nurse director stepped in, and she took over. And then stepping back allowed me to focus again on Healthcare Improvement Scotland, where our clinical staff, I'd been in touch through the whole time I was at Louisa Jordan with kind of daily meetings with them. So we deployed a clinical staff out, and a lot of them were out working in ITU and places like that. We'd other staff deployed out into NHS 24 manning phones and things. But we were increasingly aware, and we also, and speak too much about Healthcare Improvement Scotland, but we do inspections of healthcare services and independent healthcare services, but we were aware that our partners in the care inspectorate were struggling with the standards in care homes, and the outbreaks in care homes were really quite devastating. So I spent the next year working with our inspectors, working in partnership with the care inspectorate to inspect care homes who were falling over really quickly. A lot of them are really small businesses. They had been doing a great job looking after their residents up until COVID hit. But can you imagine the impact of people that you've known for maybe 2 years and you've been caring for 2 years in the care home, which is their own home, and losing out of 30, we were getting to some care homes where 15 people had died, in the previous couple of weeks. Absolutely devastating, and actually much, much more devastating than anything, that was ever going to happen that had happened in Louisa Jordan. So what we did then as a group of nurse leaders was we worked together, and the NHS nurse directors took on and still have some responsibility for ensuring that care homes who are run mostly by the private and independent sector have some quality assurance oversight, are supported with staffing and are supported with standards. And that has helped a bit, but coming out of COVID, I think it's leaving us with a whole load of questions about how do you ensure that those environments are homely, because they are people's homes and they aren't too clinical. So the whole load of things that we now need to work through that are probably part of the next leadership journey. Meanwhile, for myself, I think we had a bit of a call for everyone to go out and do vaccinations. So I did a wee bit of that before Christmas, went out and vaccinated. I hadn't done that for a number of years, and I have to say it was quite scary. So thank you to all of you who have vaccinated. My hat's absolutely off to you. I was terrified doing it, but I did manage it, and then realised that probably my skills were best used in nurse leadership. So where are we now? So in terms of coming out of COVID, in the NHS as a whole, I don't think we feel like COVID's at an end. I don't even know that it's endemic yet. I think we're still not sure. We're in the middle of another peak. We're almost at the peak, we think, for hospital admissions. The peak of infections going down. The hospital admissions have got about a 2-week lag after. And we're still faced with a number of challenges because we've got waiting lists now that have gone back 2 years, and we still need for bed space and individual space, because we've got fewer people in, and people who had held off for a long time and coming into hospital are now appearing at the door. So you'll see in the press the waiting lists and so on, massively challenged. And one of our biggest challenges, I think, at the moment is workforce. So really, really keen to engage and involve all of our new graduates, that are coming from the Caledonian, coming in and working as part of the NHS, and say bringing in that new thinking and that new energy. For myself personally, loads and loads of learning throughout my whole career. I have been so lucky to have been involved and had the opportunity to be involved in all the things that I've done. But two things for me. So I now chair the nurse directors group. So there's my own kind of leadership challenge at the moment is getting our own organisation up and running again, getting it back to focusing on helping to improve the quality of healthcare across Scotland. We've got probably a growing independent sector, and we are the regulator for them. So a lot of work, I think, in that sector, trying to get the focus back on quality and quality improvement within the NHS. And of course, we've now got the National Care Service consultation, which is kind of running on at the side at the moment. And so we're working a lot with Care Inspectorate and government around what our role might be in that as an organisation. And as Deputy Chief Executive and Nurse Director, I've got a role in leading that and setting the strategy. And that's kind of where we are at the moment. As Chair of the Nurse Directors Group, it's all about workforce actually, and all about responding, I think still responding to the crisis, but at the same time trying to find some headspace to get a future strategy together, because we know that all the issues that were there before COVID around health inequalities, around the need for improvement, around actually the shrinking workforce supply and the ageing population are all still there in droves as we come out. So for me, the next 6 months or so will be working with my nurse director colleagues to look at how we do, as part of the wider NHS system, how we address some of those. Personally, getting to the last kind of 5-10 years of my career, if I'm lucky, it's probably about legacy. So I've been really fortunate. So I'd like other people to have the opportunities that I've had. And it's about doing things like this, speaking to students and new graduates, chairing the SEN group. We've become, as an organisation, become a bit more involved in the global health network and working with low and middle income countries and looking at how we can share what we've learned with them. Working advisor to the RCN charity as well, and a lot of the work that they do is with nurses in hardship, so that's really important too. And then supporting and mentoring other staff. I suppose throughout my career, what's driven me probably has been that passion for reducing inequalities, to give other people the chances that I've had coming from similar backgrounds to me, that there shouldn't be barriers in the way. And that kind of real love of working with people, working in teams, encouraging teams. And actually, the one thing that I think the whole quality improvement movement has given me is the evidence that you're making a difference, which really, I think, to me, has made a difference as well. So happy, so that was a bit of a blather, but happy to take any questions that anyone's got. Thank you.
Thank you, Anne. That was such an interesting and inspirational talk. So we've got lots of questions there for you, so we'll try and get through as many as we can. So the first one we've got is a pre-submitted question, and this comes from Christopher, who's a graduate. And they ask, could you please describe how you made the transition from practice to policy? What, if any, the challenges were, and offer any advice for nurses who want to make a similar transition?
So I think for me, a lot of it was driven by, interest in inequalities, that there's something about being in the right place at the right time around policy as well. So I would say if policy is an area that you're interested in, then keep your eye open on what's happening politically, because a lot of it's politically led. Look at what's happening in the DOH as well as in the Scottish Parliament, and think about how you can use your skills and your roles to influence that. And don't be shy about coming to talk to people. So people who are in leadership roles, so like my own, but also leadership roles at Scottish Government, are absolutely desperate to talk to people who are early on in their careers and get new ideas and get new policy ideas. So I think if it's something you're interested in, that pursue it. Don't be shy and look for opportunities. And sometimes it's just not at the right time. So be persistent and wait till an opportunity comes up again. Don't give up. Public health is a really good one because public health is at population level, and it's a really good area to get into if you're into policy and politics. But there are other areas as well. So I think, so at the moment, the National Care Service is taking off. So anyone who can advise on health and social care at that interface, I think policymakers will be really interested in, and mental health as well. Mental health policy is a really big one at the moment too. So I'd absolutely encourage it, and I love it, but I know for other people it maybe isn't the thing.
Thank you, Anne, that's very useful. And then our next question comes from Lisa Johnston, who's on the call today. Lisa, do you want to unmute and ask your question to Anne?
Hi there. So just reminding myself of my question, sorry. So my question was, as we move out of the pandemic, there seems to have been a particular focus on mental health improvement. Prevention and early intervention was one of the areas highlighted in the 10-year mental health improvement plan. And we've seen services like DBI being set up to address kind of issues in mental health. I was just wondering, are there any new initiatives on the horizon which are designed to tackle prevention and early intervention?
So there are a lot. I mean, I would, because my passion for kind of public health, I would say there's never enough, but that there are a lot. I think one of the advantages of the pandemic, and just actually sort of just pre-pandemic, our organisation did a lot of work in Tayside. We did a couple of reviews of mental health services there and highlighted the need for improvement. So there was starting to be kind of a bit of a growth of interest. And that's for people probably with pre-existing mental illnesses. I think one of the things that the pandemic has highlighted is how vulnerable all of us are in terms of our mental health and the impact that it can have. So coming out of the pandemic, so in terms of if I split it, chunk it, in terms of the health workforce, we are now learning and are much better, I think, at supporting our workforce and the need for positive mental well-being for our health and social care workforce in order for them to deliver good care. So there's a number of initiatives around that. I think that's going to grow more. I think for me, because with an eye on the healthcare staffing legislation, one of the important things is to make sure that you've got the right numbers in your workforce, to make them feel supported, make people feel that they're doing the right job, but also things like the mental health improvement. People actually being able to openly say they're struggling, which they never could when I was at the beginning of my career, is actually a really good thing. In terms of the general population, though, there are a number of initiatives around sort of very early intervention. So the Family Nurse Partnership, for instance, for people with up to sort of 19, I think they were talking about extending to 21 young parents. We know that we'll get sort of 30 years of evidence that tells us that that's actually going to have a really positive impact on the mental health of that parent and of the children who are coming through. For people who are drug and alcohol users, there's a number of new initiatives, certainly our organisation, other organisations are working on around alcohol and homelessness to help support those people. They've had a particularly bad experience, I think, during COVID, having been socially excluded. And I think for young people, so I'm just picking a few that I'm aware of. So things like, even if you're thinking through a nursing and AHP lens, so school nursing in itself is completely redesigned. And I think if I was interested in young people's mental health now, I'd be looking at school nursing as a career, because it used to be, and I did it myself, and I could probably share many a story about standing in front of a class full of third years, teaching them sex education with some of them. So but we've thankfully moved away to that, to be much more around focusing on early intervention for young people's mental health, providing that intensive support, being very aware of the need for a CAM service and redesigning the CAM services so that it's meeting children and young people's needs. So the answer is, yeah, there's loads. Is there enough? There never is enough, but there's loads going on at the moment in terms of early intervention. I'd like to see a lot more that's focused on people living in areas of deprivation. I think because the impact of COVID in those that population, I think, has been huge, and that's where the highest number of deaths have been, as well as care homes. I think we need to do a bit more reflection coming out of COVID and do some more planning there, and we need to be, I get a bit linking back to the last question, I think we need to be influencing policy a lot more around that, but certainly there's loads there, and if you're thinking of a career there, then absolutely go for it.
Thank you.
Thank you, Lisa, for asking your question. The next question we have is from Adrian, who's a graduate, and they ask, what improvements to frontline service delivery provision do you think the new National Care Service will provide?
So I looked at this question earlier, and actually, do you know what would be really nice? So if anyone feels like putting in the chat box what improvements you think will be there, because at the moment the policy is not at a place where they've decided what's in and what's out, even in the National Care Service. What would I like to see? I'd like to see a better care experience for people. So the stuff we saw in care homes and in care at home services, and some of the experiences that people are getting again now because staffing short and people are off sick, is not where I think we want to be as a society, looking after our old people or looking after our most vulnerable. So anything that makes social care better or a better experience and gives a better experience to people who work in social care, I think would, for me, be a good outcome from the National Care Service Review. I think there's no decision made yet. There was some talk of going beyond that and having all of primary care and community health services in as part of the National Care Service. Anything that makes things more joined up for really vulnerable people who find the services hard to navigate as well, I think would be a really good outcome. But it's still, things are still very early days and things are still there on the drawing board. So actually, for those of you who are on the call who have done a wee bit of thinking about it, I'd be really interested to hear some of your ideas, and you can stick them in the chat box, I can take them back.
Thank you. Yep, I'll get your improvements in the chat box and we'll pass them on. So the next question comes from Michelle, who's a student, and they ask, what advice would you give AHP professional managers to develop advanced practice roles where there is no obvious funding?
So I think, and having done it in nursing as well, and with AHPs, it's about finding the niche. So there's a bit about having to being a bit politically savvy and lining up what you want to do with whatever is needed by the service or by policymakers or politically at the moment. So I think there are two areas at the moment where we need advanced AHPs, and one of them is in hospital at home. And the other one's in acute services to cut some of the waiting lists. So I think if for anyone, you know, any AHP manager, if you can make a reasonable argument around both of those areas, then the money will be there to develop people. The other kind of growing area, as I've said earlier on, is in mental health. And it's about making the argument not just for the profession, but actually for the good of the population that you're serving. And in this day and age, you need to make an economic argument as well. And AHPs and nurses are always a bit cheaper than some of the more expensive medicine and dentistry professions to employ too. So, but it is about just having the savvy to line up what's there, what's available, and what you want to do.
Thank you, that's great. So we've got a few messages in the chat, so I'll just take one from there. So this is from Evelyn, and she asks, what advice would you give NQN starting off in their career in terms of developing their leadership skills? I
think no matter where you are in nursing, whether you're a student nurse or you're in a position like mine, you have a leadership role. So some of it is about traditional management and managing teams. A lot of it's about actually being an advocate for your team, for the patients that you work with. Looking for opportunities to advocate, having a voice, using your professionalism. I think that's where you start off your leadership. And actually, and as I said earlier, so one of the big things for me about my leadership was learning the importance of team, but actually learning about myself. So know what your own preferences are, know what you're strongest at, develop yourself there, and use that to speak out.
Thank you, that's great. And then we've got a question here from Jessica, who's a student, and she asks, what is/was the most challenging aspect of your career so far?
So there's loads. The thing is that the thing with the really challenging things, so as I said about, not getting the job in Ayrshire and Arran was a massive challenge, but actually I learned loads. So looking back, that was a positive, because I wouldn't be doing what I'm doing now. Some of the biggest challenges I had, probably getting the nurse consultant job, which, as I said, was the first one in Scotland. It was really high profile. I was kind of interviewed and by the kind of Scottish TV and all sorts of things, and probably just wasn't really ready for it. It was probably much wider scope than nurse consultant jobs are now, because it was it was all of Glasgow, and then all of Glasgow and Clyde, a population of 1.2 million. And it was massive, and I was a bit of a kind of lone wolf at the time. I didn't have a team to work with. So I think that's probably been one of the most challenging times in my career, but it's also been a time when I learned loads and loads and loads, loads about what I wouldn't do again, loads about how I would support other people, and loads about where my strengths are and what I would do.
Yep, definitely, thank you. And then we've got another one here from Shreya, who's a student, and they ask, what is your advice for international students considering they are new to the health system in the UK?
I think, so I read this one earlier. It's a difficult one because I've been very localised, so grew up and still working in the West of Scotland. But I think for international students, I'd like to think you have the same opportunities as anyone else. And actually, you're bringing learning from whatever system or society that you've been in here. So actually sharing some of that learning is really good. I would encourage you to do in the same ways I would encourage any other student to decide and find what you're interested in at an early age, an early stage. And you can change, as I have, you can change that as you go through your career and learn and stick at that and get used to working with your team. What I've found about, we do a lot of, our organisation does a lot of work internationally. What I've discovered is we've got more things in common with other countries than we've got differences, particularly in healthcare and in caring for people, because people are people no matter where you are. So I suppose my advice would be the same for an international student as it would be for, for a kind of homegrown student, except I think you've got the added benefit of bringing learning from other systems.
Definitely. We've got time for a couple more questions. So there's one here from Abimbola, who's a student, and they ask, how have you been able to manage your time by combining work with family and other personal needs?
I sometimes wonder that myself, I have to say. So my daughter's now away at university, she's up and left us, and I look back and think, how did we manage to get her to school every day and clubs, and she played hockey at the weekends? How did we manage all that? And at the same time, look after elderly parents and all the other kind of things. But you just have to be really organised. And actually, what's good, I think now, about the health service, much better than it was when I started, is that you can say people understand that you've got a home life. Part of leadership is developed as your home life as well. You can't, everything's inextricably linked. So people, your team understand that there's times that you go through where you've got other people that you're looking after and things that you have to do, and you'll help them out when they're doing it as well. So there's a bit about being really organised and something about really honest and open with other people that, okay, I might be in a really senior job or I might be in a really busy job, but actually there's a life outside of this. And if, and I'll understand everybody else's. One of the first things I do if I get a new team member is, ask them, about their family and, how they're at home, what matters to them, what hobbies they like, so that we can make sure if they're coming into our team, all of that's supported. Because if people are happy and able to support their home life, they can be happy and supported at work. I kind of, in doing that, get that back from the rest of the team.
That's brilliant, thank you, so true. We've got time for one more question. So this comes from Blessing, who's a student, and they ask, what is your main motivation? What keeps you going?
I think it is, so early on in my career, it was, when you're working kind of frontline acute nursing, the motivation there was you get immediate feedback from patients. And you would go off a shift, sometimes you go off a shift feeling really awful, but most of the time you go off a shift feeling really good, thinking, oh, I made a difference there. My motivation now is probably the same, but much broader. So I like the thought that I'm still making a difference to people who are receiving care or, coming into contact with services. The last 2 years, one of the biggest challenges, probably one of my biggest challenges in my career actually, has been my inability to then go out and link with them, or link with the people who've been providing that frontline care, to get that kind of evidence back that what we're doing is making a difference. But I think definitely motivation is, nobody comes into nursing because of motivation's money. So definitely, although I'm kind of well paid now, I think definitely the motivation is just that feeling that you're making a difference, feeling that you're reducing inequalities, feeling that whatever you've done in that day has, has improved an outcome for someone. And every so often in kind of senior leadership jobs, being able to go out and walk the floor and actually get some evidence of that.
Thank you, Anne, that's great. We really appreciate you being here today, and sorry we've not managed to get round to all the questions, but Thank you very much. I'm now going to hand back over to our principal, Professor Pamela Gillies, to close today's event. Thank you.
Thank you so much. Well, Anne, my goodness, what a fascinating Captains of Industry talk that really was. It was so inspiring to hear your personal story, your honest reflections, and all about your career journey. And have to say, Anne, I'm so impressed by your personal lifelong commitment to social justice and to reducing inequalities. And I, for one, am so very glad that you stuck to being a nursing angel rather than one of Charlie's angels. What an amazing contribution you've made and you continue to make to our NHS and our National Care Service. We're so fortunate to have nurse leaders like you in our system. But, you know, listening to your story, you're absolutely inspiring our current nurses to take on that leadership role themselves, to understand, as you said, everybody needs to be a leader in some aspect of our care and health services today, and they all need to step up. And I love the way you talked about just open those doors of opportunity, you know, have a go, and you'll, as you said, you learn more sometimes from the jobs you don't get than the ones that you do. So that was so interesting. You're such an interesting person. Thank you so much, Anne, and we really appreciate it, and we'll get back to you with any suggestions our audience today have for some of the challenges you put to them. Thank you.
Thank you, thank you. And I'm on Twitter and LinkedIn and other things, so absolutely happy for folk to contact me if they want a bit of advice on mentorship or want to come in and visit us in Hess and see what we do. Yep.
You're a star.